Welcome back guys. Now in this video let's discuss about pericardial disorders. Now before discussing about the pericardial disorders, I just want you to know what exactly is pericardium and it's made up of how many layers, right? So we all know heart is made up of 3 layers, the inner endocardium, myocardium and pericardium. Now if you look at the pericardium, see, now the innermost layer which I am showing here in red color, that's the endocardium. After endocardium, the middle layer which I am highlighting right now, this layer which I am showing with the black point is the myocardium, okay. But outer to the myocardium, what do we have? Pericardium. See, this pericardium, it is having mainly 2 layers, okay, the serous layer and the fibrous layer. Now, what exactly is this serous layer? See, now whatever I am highlighting right now, okay, whatever I am pointing right now, see, this is called as the visceral pericardium, okay, that's called as a visceral layer. That's a visceral layer of serous pericardium, and this layer which I am pointing, which is more towards outside, that's called as parietal layer. Okay, there is visceral layer and parietal layer. See, both this visceral and parietal layer together, they are forming serous pericardium. Okay, they are forming serous pericardium, right? And the space between the visceral layer and parietal layer, this space is called as a pericardial cavity. Okay, pericardial cavity. See, this pericardial cavity is the space where pericardial effusion will happen. If in certain pathologies, if fluid is accumulating around the heart, see in which space the fluid is going to accumulate. In pericardial effusion, in pericardial tamponade, the fluid is going to build up around the heart. In which space? This space is called as the pericardial cavity, and this pericardial cavity is the space between the visceral layer and parietal layer of serous pericardium. Now here itself I want you to know, see this visceral layer, okay, this visceral layer which I am highlighting, this visceral layer is also called as the epicardium. Okay, so the visceral layer of serous pericardium is nothing but the epicardium. Okay, so what is this layer which is outermost? This layer which is in the yellowish color or the golden color, that's the fibrous layer. Fibrous layer of the or I should say the fibrous pericardium. Fibrous pericardium. So now you know what exactly the pericardium made up of. The pericardium, it is having the inner serous pericardium, outer fibrous pericardium. The serous pericardium is again having 2 layers. One is the visceral layer and other is the parietal layer. The space between the visceral layer and parietal layer is called as a pericardial cavity. Just for integration purpose, I am telling you here itself, the pericardium, it is innervated by which nerve? Pericardium is innervated by phrenic nerve. Okay, and that's also an MCQ. In pericardial pathologies there will be pain, right? So the pain is going to go through the phrenic nerve. It's innervated by the phrenic nerve. Now after this, let's talk about the pericardial pathologies. The first pericardial pathology which I want to discuss is pericarditis. So what exactly is pericarditis? So pericardial inflammation. The name itself is there. Pericardium itis, pericardial inflammation. What is the cause? What are the causes of pericardial inflammation? Okay, what is the etiology? The etiology is unclear. We don't know the exact reason how pericarditis happen or why pericarditis happen, we don't know. But there are certain conditions which can lead to pericarditis. The one important point which I want you to know is the post-MI pericarditis. Post-MI means after myocardial infarction, certain cardiac antigens or the pericardial antigens will be exposed to the immune system for the first time. So, autoantibodies are produced against the pericardium. Simple. After MI, some individuals will develop pericarditis, post-MI pericarditis. During myocardial infarction, certain myocardial antigens, certain cardiac antigens are going to be exposed to the immune system. So, the immune system is producing antibodies against the heart, against the pericardium, leading to the inflammation. So, that is called as a post-MI pericarditis, which is also called as a Dressler syndrome. Okay, Dressler's syndrome. And pericarditis can be seen in the conditions of uremia, the kidney failure, uremic depositions in the pericardium can lead to the pericarditis, and the bacterial infections, especially TB, can lead to pericarditis, or viral pericarditis can be seen, like viruses like Coxsackie, Coxsackie virus. All of them, they can lead to the pericarditis. Now, what are the clinical features of the pericarditis? If one have pericarditis, I am just trying to integrate the medicine. Again, pathology won't get all these things, but these are important things. What are the clinical features? The patient is going to have chest pain. Okay. Now, this chest pain need to be differentially diagnosed. You need to differentially diagnose with the ischemic chest pain. Okay. Say if there is ischemia and myocardial infarction, definitely there is going to be chest pain, ischemia and anginal chest pain. How to differentiate the ischemic chest pain with the pericardial chest pain? You need to differentially diagnose. How to differential diagnose is this pain is going to be sharp pain. Sharp pain. Because the ischemic pain is a dull and diffuse pain. Okay, it's not going to be pointed or localized. If you are having ischemia and that's leading to angina, the chest pain, it's going to be dull and diffuse. It's not going to be single pointed. It's not sharp. Anginal pain is not sharp, but the pericardial pain is going to be sharp, and this pain increases with deep breath. Okay, with the deep breath, the pain is going to be increased. Means with the inhalation and exhalation, with the inhalation, with the deep breathing, the pain will change, the pain will alter. But the pain in myocardial, but the pain in ischemia, the ischemic pain or the anginal pain does not vary with inspiration or expiration. Okay, that's an important point. And here the pain in pericarditis, yes, increases with supine position. Okay. With supine position, the pain is going to be increased. When with supine position, more blood flow will be there. The pericardial layers will stretch. The stretching of the pericardial layer with the supine position can lead to more pain. And if the patient is in supine position, the pain will be more. But if the patient is now coming to the standing position or sitting position, the pain gets better. Okay, pain gets better with sitting position. Sitting or leaning position. Okay, these are the important points which I want you to know. So, the pericardial chest pain is going to be a sharp pain, and you need to differentially diagnose with the ischemic pain. How to differentially diagnose? The pain is going to be sharp in nature. The pain increases with the deep breath, means with the change in the pattern of breathing, the pain will also change, but the ischemic pain does not vary, something like that. Okay, and pain increases especially with the supine position, but pain gets better with sitting or leaning position. Okay, now if a patient is having this pericarditis, now the patient is having pericarditis and he is going to present to you with the clinic with a chest pain. Now whenever there is a chest pain, what you like definitely order, definitely you will think that this is an ischemic chest pain, and definitely you will order for an ECG, okay, for looking the ECG changes. Now in pericarditis, even in the topic of rheumatic fever, I have discussed that if a patient is having pericarditis, there will be ST elevation, okay, ST elevation, but little different. See, here the patient is having ST elevation, look here. Okay, there is ST elevation. in all the slits there is ST elevation. Okay. But something important is this ST elevation is concave, not convex. In myocardial infarction, in STEMI, ST elevated MI, there will be convex ST elevation. But here the ST elevation is going to be concave. Now, look here, especially it's very much visible in V6. It's a concave ST elevation. ST segment is elevated. So here, when compared to the baseline, ST segment is elevated, but it is concave. Okay. Concave ST elevations are especially seen from V4, V5 and V6. That's the one ECG change which you should know for your exams for sure. Okay, there is widespread concave ST elevations. And not only that, the patient with a pericarditis on EKG will have PR depressions. Okay, the PR segment we know. See this PR segment starting from the P to the Q. This PR segment is going to be little depressed. It's not very much visible over here. It's little visible in this V1. If you look, see, this is the PR segment, right? This PR segment, it is little bit downward. So, there is a PR depression which can be seen. Okay, let me show you in other ECG, it's better visible. Now, you look here. There is ST segment elevation that took concave ST segment elevation. When compared to the baseline, this is the baseline. That's not the baseline. This is the baseline. Okay, this is the baseline. When compared to the baseline, yeah, there is little elevation is there, but that took concave. And what else is there? This PR segment, this is the PR segment. Look here, the PR segment, it is getting depressed. Okay, there is a depression of the PR segment. Here also, there is PR segment depression. See, the PR segment is going to be depressed and there is concave ST elevation. Okay, better visible here, see, there is PR segment depression and concave ST elevation. Here also, the PR segment, okay, this is the PR. The PR segment is going to be depressed and it is the concave ST elevation. Okay, there is a caving, right, something like that. So these are the EKG findings. So now tell me, if a patient is having pericarditis, yes, there is chest pain, but it's a sharp pain, varies with the position, sharp pain that varies with respiratory patterns. Okay, and if you do electrocardiogram, in electrocardiogram, what you can appreciate is ST segment elevations with a concavity. Not only that, there will be PR segment depressions. Now, here in this slide, I am just trying to show different types of pericarditis, which is not that much important, but I will tell you. See, the pericarditis, it is divided into two types, acute pericarditis and chronic pericarditis. If it is happening suddenly just like that, it's acute pericarditis within a short period of time. Yes, it is acute pericarditis. This acute pericarditis can be fibrinous, a type of pericarditis, serous, hemorrhagic, caseous. Important MCQs which you should know is, if the patient is having, or I should say, the most common type of pericarditis is fibrinous pericarditis. It's the most common type. We have discussed, like, bread and butter pericarditis, an example of fibrinous pericarditis, which is seen in the rheumatic fever. If a patient is having uremia because of kidney failure or post-MI Dressler syndrome, all these are example of fibrinous pericarditis because there is a fibrinous deposition in the pericardium. Okay, the pericardium, there is fibrinous material is going to be deposited. If in the pericardium, if the fluid is getting deposited, serous accumulation, if there is a serous accumulation, then it is called as a serous pericarditis, serous accumulation. Okay, hemorrhagic pericarditis means there is pericarditis with accumulation of blood. Okay, you can very clearly see there is accumulation of blood over there. It is seen in trauma, malignancies and TB. But the very important point which I want you to know is, look here, this is the pericarditis in which the pericardium is almost looking like a cheesy thing. Okay, so this is called as a caseous pericarditis, which is seen in the cases of TB. Okay, cheesy appearance, which is seen in TB. So in TB, other types of pericarditis can also be seen, but if they ask you, caseous pericarditis is seen in TB. Okay, that's the one important MCQ I want you to know. After a long time, pericarditis is going to be healed. Definitely, it's going to be healed. And now that's a chronic pericarditis. The patient is having pericarditis for many episodes, and it is going to be healed. Then it is chronic pericarditis. Okay, now whenever the patient is having chronic pericarditis, the healed area, okay, the pericardium is going to be healed with the scar formation. Now you can very clearly see here this whitish area. Okay, this whitish area, it's a healed pericardium. So it is called as milk spot or soldier's plaque. So soldier's plaque or milk spot, it's nothing but the fibrotic area. It's a pericardial fibrosis which is seen in the chronic pericarditis. Okay. So now after this, let's discuss about other pericardial pathologies. The next pericardial pathology which I want you to know is pericardial tamponade. Okay, pericardial tamponade. So what exactly is this pericardial tamponade? Normally, in the pericardial cavity, there will be some amount of pericardial fluid. Normal, that's something normal. Some amount of pericardial fluid is going to be there in the pericardial cavity, which I have already discussed. Now, if there is a little bit more fluid because of some pathological reason, if there is a little bit more fluid, then it is called as pericardial effusion. But there will be too much building up of the fluid or blood, whatever. There is too much fluid accumulation in the pericardial cavity. Now this fluid is surrounding the heart and it is compressing the heart from all the sides. Okay, so compression of the cardiac chambers because of the accumulation of fluid around the heart. It is called as a tamponade. Tamponade is nothing but a severe form of pericardial effusion. Pericardial effusion is just fluid around the heart. But if this fluid is compressing all the cardiac chambers, then it is called as pericardial tamponade. Okay. Now, you can very clearly see here. See, this is the heart which I am highlighting right now. On my top, you can see this is the area of the heart. Now, whenever we are just cutting open the pericardium, you can very clearly see that the pericardium is having a lot of blood. Okay, inside the pericardial cavity, there is a lot of blood. Now, what this blood will do? This blood will actually compress the cardiac chambers from all the directions. From all the directions, the heart is getting compressed. Okay, even in this image, you can very clearly see in the pericardial cavity, there is fluid accumulation. If there is just fluid accumulation, then it is called as a pericardial effusion. But once this fluid, once it starts compressing the cardiac chambers, then it should be called as a tamponade. Okay, that's a point which I want you to know. It's a little serious condition. Now you can ask me, sir, from where this blood is coming. Okay, in this condition, from where this blood is coming. Imagine, let me give you a small example. For example, here I am showing you the left ventricle. Okay, this is a left ventricular wall. I am only talking about the left ventricle. Okay. Now, this left ventricle, it is surrounded by pericardium or not? Yes, it is surrounded by pericardium. Okay, this green color layer which I am showing you here, this is the pericardium. Okay, in detail I have discussed all the different layers of the pericardium. Now, imagine this patient is having a myocardial infarction in this area. Okay, this myocardial infarction, this area of the heart is getting infarcted. Now, whenever there is myocardial infarction, definitely it's going to heal after some time. Luckily, this patient is survived and this area of the heart is going to heal. But this healed area doesn't have a proper strength. After myocardial infarction, there is a chance that this area, okay, this area, it will undergo rupture. There is myocardial rupture. The heart is going to be ruptured. Whenever there is rupture, what happens? All this blood, whatever is there in the left ventricular cavity, all this blood, now it will leak. Now it will leak into the pericardial cavity. Okay, from the left ventricular cavity, the blood is going to leak into the pericardial cavity. Now, what happens? Now, all this blood is accumulating in the pericardial space. Now, what happens? This is the first, initially there will be pericardial effusion. After some time, because of the accumulation of the too much amount of the fluid, now this pericardial effusion, it will transform itself into cardiac tamponade. It will start to compress the heart. This fluid will start to compress the heart. So, that is the pathology. That's how it happens. Okay. So, now let me write here for you. This is the accumulation in cardiac tamponade. Okay, even in echocardiography, see, this is the echocardiography where you can very well appreciate these are the chambers, these are the cardiac chambers, these are the heart chambers. Now, see, around the heart chambers, there is fluid accumulation, there is pericardial effusion. This pericardial effusion is the one which compresses the cardiac chambers. Okay, that's what I want to put into your mind. Now, what is happening? It's the accumulation of fluid or the blood in pericardial cavity leading to compression of heart chambers. okay, leading to the compression of the cardiac chambers. Now, what are the causes? Now, what causes can lead to this pericardial tamponade? Pericarditis. Okay, so pericarditis can lead to the cardiac tamponade. Pericarditis, the serous pericarditis, especially accumulation of the serous fluid, can lead to the cardiac tamponade. Uremia. Uremia can lead to pericarditis, and pericarditis can lead to the tamponade. And metastasis, cancer metastasis. Okay, cancer metastasis can lead to tamponade or trauma. Okay, for example, I have already given you, for example, whenever there is a direct trauma or post myocardial infarction, there is a rupture of the myocardium or the heart chamber can lead to the pericardial tamponade. Now, in this pericardial tamponade, the important points which I want you to know is, see, the patient is going to have, whenever you do the EKG, this is a more life-threatening condition. Okay, why it's more life-threatening condition, I will explain you. But whenever the patient comes to the hospital and whenever you perform the EKG, what you will see is, first of all, there is a low voltage EKG. Low voltage. You can very well appreciate that all these waves in the EKG, they are very, very small. Why? Because now the heart is totally surrounded by the fluid. Now this fluid does not conduct the electricity properly to the leads. Okay. Now the heart is totally, it was surrounded by this fluid, right? So the electrical conduction is not happening properly. So whatever the EKG waves that are coming, there is low voltage. They are small waves. Okay. So low voltage EKG is going to be seen. Remember, and this low voltage EKG will also be seen in a condition called as constrictive pericarditis that we will discuss later. But remember, whenever you see a low voltage EKG, you should think about cardiac tamponade. And not only low voltage EKG, you can also appreciate something called as electrical alternance. Okay, what is this electrical alternance? Electrical alternance means, please look here, there is high voltage coming and low voltage coming. Bigger waves, smaller waves. Bigger waves, smaller waves. So, what exactly is this? Why exactly is this happening? Okay, on one time, like a bigger QRS complex is coming, smaller QRS complex, a bigger QRS complex, smaller QRS complex. So, this pattern of EKG with a bigger and smaller QRS complexes alternating with each other is called as the electrical alternance. How I used to remember is, now see, the heart is now totally surrounded by fluid. Now heart is in a fluid filled cavity. Heart is now floating in a fluid filled cavity. It is beating. While it is beating in such a fluid filled cavity, now the heart is moving. Okay, imagine now the heart is surrounded by the fluid, and now while the contraction, the heart is little wobbling. Okay, while it is wobbling, it is coming near to the chest and it's going back. It's coming near to the chest and going back. Why? Because it's totally, it's like in a swimming pool. Okay, now this wobbling of the heart can lead to this electrical alternance. Sometimes it's coming near to the chest, leads, and it's going back. It's coming to the leads, it's going back. So this movement, I used to remember something like this. Okay, this movement or this wobbling of the heart is the one responsible for this alterations in the QRS complexes. Okay, bigger QRS complexes and the smaller QRS complexes. So this is called as electrical alternance. So now tell me, if you perform this EKG in a patient who is suffering with this cardiac tamponade, the two things which are appreciable are low voltage EKGs as well as the electrical alternance. Now, what else you should know is the patient with the tamponade is going to have something called as Beck's triad. So what exactly is this Beck's triad? Let me tell you, in tamponade, the patient is having Beck's triad. This Beck's triad include low BP and distended JVP, distended jugular venous pulses or pressures, muffled heart sounds. Muffled heart sounds. See, these three together, they contribute to the Beck's triad. They are coming under the Beck's triad. So why exactly is this? Simple logic. Now heart is surrounded by a fluid filled, heart is surrounded by a fluid, or heart is surrounded by the blood. Now the blood is getting clotting. Okay, now blood is getting clotted. Now do you think proper conduction of sound will happen? The totally heart is surrounded by fluid, man. So whenever you try to auscultate, are you able to clearly hear the heart sounds? Definitely not. There will be muffling of the heart sounds. Okay, so muffled heart sounds are seen. Okay. Now why the jugular venous pressures are going to be distended? Think logically. Now imagine this is the heart. Okay, here is the heart with the 4 chambers. Okay, this is the right atrium. Now heart is surrounded by what? Heart is surrounded by fluid, or maybe the blood. Now when the heart is surrounded by the blood, what this blood is doing? This blood is compressing the cardiac chambers from all the directions. So right atria is also getting compressed, left atria, left ventricle, everything is getting compressed, right? Whenever the right atria is getting compressed, what happened to the right atrial pressure? Right atrial pressure increases. Okay, right atrial pressure increases. Right atrial pressure is nothing but the central venous pressures. When the central venous pressure increases, do you think that the jugular veins or the superior vena cava can drain into the right atria? Already the right atrial pressure is more. So do you think proper venous drainage will happen into the right atria? No. Right atria is getting compressed. So proper venous drainage into right atria does not increases. Right atrial pressure is more, so central venous pressure is going to be more. So that jugular veins are also going to be distended. No proper drainage. Okay, so that's the one responsible for the distended jugular venous pulses. Okay, the jugular venous pressures are going to be more. And what is the other component of the Beck's triad? The other component of the Beck's triad is low BP. Okay, why there is low BP? Simple. The left ventricular cavity is getting compressed. Whenever the left ventricular cavity, whenever it is getting compressed, do you think proper filling will happen? No, proper filling is not going to happen. So the ventricles are not getting filled properly. Whenever the ventricles are not getting filled properly, do you think cardiac output will increase? No, the cardiac output will decrease. Okay, the cardiac output is going to be decreased. Whenever the cardiac output decreases, BP decreases, especially the systolic blood pressure decreases. Okay, BP decreases. Why? Because cardiac output is getting decreased, BP decreases. So this is the these are the important points about the Beck's triad. So Beck's triad include what? The Beck's triad include the low BP, muffled heart sounds, as well as the distended jugular veins, which are seen in a patient who is suffering with cardiac tamponade. And whenever you do the EKG shows low voltage EKG with the electrical alternates. What else can be seen in these patients? Let me write here. These patients with pericardial tamponade, they usually have something called as pulses, paradoxus. Okay, so what exactly is this pulses paradoxus and why it is seen? Normally during inspiration, okay, BP decreases. Remember, this is something normal. Normally during inspiration, the BP decreases. Okay, but it is less than 10 mmHg. Okay, when compared to the expiration, during inspiration, say right now, I am inspiring. Whenever I inspire, okay, this will be done in the physiology modules. Whenever we do inspiration, BP usually decreases. How much decrease? The decrease in the pressure will be less than 10 mmHg when compared to expiration. And this is something normal also. Okay, this is something normal. But in tamponade, there is more than 10 mmHg fall in BP. Okay, so the BP is going to fall more than 10 mmHg. Then it is called as, with inspiration, if the BP is falling by more than 10 mmHg, then it is called as pulses paradoxus. Okay, pulses paradoxus, PP. Okay, I am writing in a shortcut. What is pulses paradoxus? Simple. Pulses paradoxus is vigorous fall, exaggerated fall in the blood pressure during inspiration. How much fall? More than 10 mmHg. Some books mention more than 10 mmHg, some books mention more than 12 mmHg fall. It is called as the pulses paradoxus. Now, what is the pathophysiology in this pulses paradoxus? First thing which you should never forget is, now look here, the heart, okay, it's having the 4 chambers. Now, right now, the heart is surrounded by the blood or the fluid. Now, the heart is totally surrounded by the blood or fluid. Now, what this fluid is doing? This fluid from all the sides is trying to compress the cardiac chambers, something like this, right? Keep this point in mind. What happens during inspiration? See, when the person is doing inspiration, okay, when the person is doing inspiration, there will be negative pressure that's going to generate in the thorax. Okay, in the thorax there will be negative pressure that is generated. Now it will suck the blood from all the sides. It will suck the blood. Okay, so inspiration, what will happen? There will be increase venous return. Okay, there is increased venous return. Whenever the venous return increases, this happens in a normal person also. Okay, whenever there is increased venous return, what happened to the right atrial size, and what happened to the right ventricle side? More and more blood is coming, right? More blood will come to the right atria. From the right atria, more blood will come to the right ventricle. Now, increase in right ventricular size. Normally, during inspiration, right ventricle will receive more blood and right ventricle will enlarge in its size. But now see, the right ventricle cannot enlarge now. In this pericardial tamponade, now the right ventricle cannot enlarge outside. The wall cannot expand outside. Why? Because for all over the heart, surrounding the heart, there is fluid present or the blood present. The blood is clotted around the heart. Now the right ventricle cannot expand outwards. Now what happens? In order to accommodate this blood, okay, in order to accommodate this blood, now right ventricle or the right ventricular septum, it will deviate. Now let me show you what exactly happens is, this right ventricular septum, this is the interventricular septum, right? This interventricular septum, I should say not right ventricular septum, interventricular septum. In order to accommodate that extra blood, whatever is coming during the inspiration, now it is getting more deviated towards the left ventricle. So, increase in the right ventricular size, what it is doing? It is causing the bulging of the septum. Bulging of septum into LV, into the left ventricle. So, into the left ventricle, the septum is getting bulged. Now, whenever the septum getting bulged into the left ventricle, what happened to the left ventricular cavity size? So, left ventricular size is getting compressed. Already from outside the left ventricle is getting compressed. Now even the right ventricle and the interventricular septum is compressing the left ventricle. So the left ventricular size decreases, the left ventricular filling decreases. So whenever the left ventricular filling decreases, automatically the left ventricular output or the stroke volume automatically decreases. So whenever stroke volume decreases, BP decreases, simple. So left ventricular size decreases. So left ventricular filling decreases. So left ventricular filling decreases means what happened to the stroke volume? Stroke volume decreases. This decrease in stroke volume decreases the BP. Okay. So when there is decrease in BP, more decrease in BP. When there is more decrease in BP? During inspiration. So in a condition called as a pericardial tamponade, there is a more exaggerated fall. That's the important point. Okay. There is more exaggerated fall in the BP, that is more than 10 mmHg. Why? Because during inspiration, normally there is more venous return. More venous return increases the right ventricular size. The right ventricular septum, I should say not right ventricular septum, the interventricular septum. The interventricular septum, it will bulge into the left ventricle. The left ventricular cavity size decreases, left ventricular filling decreases, stroke volume decreases, automatically BP decreases. Okay, why? Because BP, especially the systolic BP, depends on the stroke volume and the cardiac output, right? So that's what happens in the pulsus paradoxus. What else can be seen in a patient who is having this pericardial tamponade is changes in jugular venous pressure tracings. Okay, jugular venous pressure tracing, there are some changes. What are these changes that are seen? There is prominent X descent. Prominent X descent is seen on the jugular venous pressures as well as blunted Y descent. Okay, blunted Y descent. So how to understand these things? Okay, how to understand this JVP changes? We have discussed the jugular venous pressures in detail in the physiology modules, but here I will just give you a brief idea. Okay, so now this is how the jugular venous pressures are going to be. Okay, see A wave, C wave, X wave, V wave and Y wave. Okay, A, C, X, V and Y. Now what I am discussing? The X wave is going to be more prominent. The X wave is going to be more prominent and Y wave is going to be blunted in pericardial tamponade. Why it will happen? I will try to explain. See, this is how the waves are going to be. In pericardial tamponade, the jugular venous pressures will become something like this. Okay, see how prominent the X wave is. The X wave is more steeper now when compared to in the first condition. The X wave in this condition is more of having, okay, let me draw in a better view. Now, see, A wave is like this, X wave, V wave and Y wave. See, now the X wave is more steep, okay, more steep, it's more prominent, and Y wave is blunted, okay, the Y wave is blunted. Why it is happening? Remember, in physiology modules we have discussed this X wave, okay, the X wave in jugular venous pressure tracings, it is because of what? Atrial relaxation. Relaxation will cause the X wave, okay. Y wave is because of what? Atrial emptying, EMPTY, emptying of the atria, especially right atria. Emptying of the atria will cause the Y wave. In pericardial tamponade, what is happening? See, imagine here is the right atrium, here is the right ventricle. Okay, I am only talking about the right side of the heart. Okay, why? Because jugular venous pressures mainly depend on the right atrial pressures. Okay, now this is right atria, this is right ventricle. Okay, right atria and right ventricle. Now, what is the valve between them? The valve between them is the tricuspid valve, you know it. Also, you know, in this condition, the heart is totally surrounded by the fluid. There is a tamponade, pericardial tamponade fluid is there. Okay. Now see, when atrial relaxation happen, tell me, when atrial relaxation happen, atria are going to be seen. When atrial relaxation happens, ventricular contraction will happen. See, when the ventricle is contracting, atria will undergo relaxation, right? When the ventricle is contracting, the atria will undergo relaxation. So, what I am trying to put into your mind is, see, this is the pericardium which is surrounding the heart, okay? When the ventricle is undergoing contraction, see, ventricle is undergoing contraction. When the ventricle is contracting, the ventricular volume decreases, ventricle is becoming smaller. When the ventricle is contracting, now what happens? The ventricular size is decreasing, so there is a more space here, the space increases. Okay, now here the downside, the space increases. Whenever the space increases, whenever the pericardial space, the pericardial cavity size increases, what happens? All the fluid which is present around the right atria, it will come down, it will fall down. So now what happens? Right atria, it will undergo very fast relaxation. Okay, now there is no fluid around the right atria. When the ventricle is contracting, try to concentrate on my words. When the ventricle is contracting, the ventricular cavity size decreases. So now there is more space around the right ventricle. There is more space around the right ventricle. When the right ventricle is contracting, the right ventricular size decreases. So there is more space around the right ventricle. Whenever there is more space available around the right ventricle, the blood which is surrounding the right atria, it will come down. So now now the right atria, it will undergo easy relaxation or vigorous relaxation. Okay. Now let me show you in another way. See, Now ventricle is undergoing contraction. Okay, this is the right atria. These are the walls. When ventricle, it is undergoing contraction, right ventricle. Now see, this is the pericardium, right? Okay. Now when the ventricle is contracting, there is more space available here around the ventricles. So all the blood, whatever is there around the right atria, it will fall down. So now right atria can undergo easy relaxation, fast relaxation. So whenever there is fast relaxation, tell me, the relaxation is noted with X wave. Okay, relaxation is noted with the X wave. So whenever there is fast relaxation, there will be steep X wave. So that's why in this condition, the wave, the X wave is also going to be steep, very fast, steep X wave. Okay, so that's the prominent X descent is going to be seen. Now second thing, why there is a blunted Y descent? Atrial emptying, when the atria empties, okay, when the atria empties the blood into the ventricles, that will cause the Y wave. Okay, that will cause the Y wave. Now tell me, in pericardial tamponade, what happens? You know, this is the right atria, this is the right ventricle, okay, this is the wall. Now totally the heart is surrounded by the fluid, okay, pericardial fluid is there. Now this pericardial fluid, what it is doing? It is compressing the heart, it is compressing the ventricles also. Now when the ventricles are compressed, okay, do you think proper filling, proper atrial emptying will happen? Okay, easily the atria can empty. Do you think easily the atria can empty down into the right ventricle? Right atria can easily empty down into the right ventricle? No. Because right ventricle is getting compressed, right ventricular pressures are more, so it's not easy to fill the right ventricle. Right? Because already the right ventricle is getting compressed, the right ventricular pressures are more. So it is hard for the right atria to fill the right ventricle. It's not happening easily. So that's why the Y wave is blunted. Okay, so the right atrial emptying, it is happening slowly. Okay, not fastly, slowly. So that's why there is blunting of the Y wave. There is blunted Y wave. So these are the changes which are seen in pericardial tamponade. So one by one, tell me what exactly is pericardial tamponade? Pericardial tamponade is a serious condition. It severely decreases the BP. The entire heart is getting compressed. When the heart is getting compressed, the heart will not fill properly. When the filling is not there, when the heart is not getting filled, from like cardiac output cannot be maintained. When the cardiac output is not maintained, the BP decreases, the person can die. It's a very serious condition, right? So what are the important points that you should know regarding the pericardial tamponade? See, the causes are not that important. Important points are the electrical alternates. In the EKG, we'll see the electrical alternates as well as the low voltage EKG. The patient is going to have the Beck's triad, the muffled heart sounds, the distended jugular venous pressures as well as the low BP, and the patient is also going to have the pulsus paradoxus, which is nothing but the exaggerated fall in the BP during the inspiration, more than 10 mmHg fall, and in the jugular venous pressures there will be prominent X descent and blunted Y descent. Okay, prominent X descent and blunted Y descent. So these are some important points which I want you to know regarding the pericardial tamponade. Hope the video is helpful. In the next video, we'll discuss about constrictive pericarditis and some important points. Hope the video is helpful. Thank you.